The governor of Nakuru County with my colleague Ibrahim Karanja. You want to stand by for that. But before we went for the break, we were still discussing matters midwives and the voices of midwives. And, Mark, you were talking about, the roles, the distinction and the roles of the importance of to the service providers, the clients, and also the midwives as well. What about now the importance and the significance of midwives for the service providers?
Okay, you see, one, getting back to the state of the midwifery in the country, one, we realize that midwifery number of midwives in Kenya, qualified midwives, are very low, significantly low. And you realize that we have a deficit of over 900,000 midwives in Africa.
That's about 1 million.
Yes. So you realize that most of the countries have not invested in midwives. So we can't go to to provide quality midwifery services if we don't have the numbers. We are taking a nurse and we are using that one unit in their curriculum to provide quality services in midwifery. It's a bit challenging because we are taking a nurse who is trained in all other aspects, then we are putting him in to provide services, quality services. So one, we have a significant low number. Two, the midwifery are not, it's not a point of interest to most of the facilities, most of the systems. So again, we urge our stakeholders, let's invest in this midwifery. Let's invest in midwives. Let's give them a clear path. Let's train them. Let's give them a mandate. You are trained to be midwife. Go and provide midwifery services to a midwifery center, be it a maternity, be it a birth center. At least we shall see value in the training.
And Sandra, talking about the investment and advocacy for midwives, it is not the norm to see gentlemen taking up the role of midwifery. From where you sit from an advocacy perspective, are we seeing more men taking up this role, or is it still traditionally women? And is even there a stereotype for people like Mark who choose to take up that role?
Excuse me. So in terms of midwifery, actually we've come to see currently it is still very female dominated, and that is one of the call to actions that we're even making in this campaign. That we are calling more men to actually take it up as a profession. You see, the impact of it being female dominated is actually quite deep. It is because of it being female dominated, we're actually seeing some certain iniquities and inequalities because of gender. One example is pay equity. You find that because a number of midwives are women, the way they're remunerated, and that is one of the key asks that has come out of this campaign, is quite poor. They want to be actually paid for the work that they've done, a heavy workload, equity in terms of versus what their male colleagues are getting. And maybe he can speak to even how, if that's a difference in his case. But then also in terms of leadership opportunities, we are talking about, and he's talked about career progression and opportunities. You do find that midwives are not given, there's no spaces for them in leadership. They've asked for positions in the county government and national government, where we have the county nurse officer. In other countries, we have the national nurse officer. And even now, as we are pushing this campaign, we are starting to see spaces opening up. We are seeing chief midwifery officers, director of midwifery, as he said. And this is, I know a number of them are women, but this is one call that we're making. Can we also get men on board? Because when we get them on board as allies, as champions, as partners in midwifery, but even as midwives themselves, we'll actually see a shift in how they're perceived and how they're recognized and respected.
And talking about shifts and the call to action, Mark, first of all, I'm curious, when you are walking the journey with an expecting mother, do you always face, a setback when a lady or a mother sees it's a gentleman attending to her?
You see, something interesting, most of the clients, most of the mothers, the pregnant mothers, they mostly prefer to be delivered by a male gender midwife.
Oh, really?
Yeah. I think we can get a feedback from them, actually. But I think how a man will relate to a woman, there is a bit distinct difference. But again, most of the men who are doing midwifery, we give it all when it comes to how we are helping the mothers. And again, the whole midwifery process, you do it with a lot of passion, a lot of love, because this is a mother in pain. This is a mother who needs your comfort. This is a mother who needs your support. So again, it is not very challenging as such, because we interact with people, different backgrounds, different gender and all that. But it all comes out as a passion to give the quality services as if you are giving to your own person. Yeah.
So Mark, the remuneration, because one may be, developing interest, as you say, in high school, and then proceeding perhaps to, college and then later university. Is this a career worth pursuing? Is the remuneration worth it? Because at the end of the day, people have to pay bills, they have to survive. But one might ask, how much of an investment worth is this?
I'll say as a country, we are a very fertile country. And at any given time, even as we speak, several mothers are giving birth as we speak.
Yes.
In every second, we have very many mothers delivering, right, in dispensaries, in birth centers. So you see, it's not like something that has a timeline. As in, let's say by 2030, there'll be no midwifery. By 2050, there'll be no APANA. It's something that is ongoing. So you realize that mothers are giving birth every day. So the demand is always there for midwives. Every time, the demand is always there. You go to very busy facilities, there are deliveries of 100 in a week. You see, so there's always demand and there's always need for that particular service to be provided in the best way.
So that is a profession you encourage, it's all the cause?
Yes.
Okay, great. Sandra, coming to you, why is it important to invest in midwifery in Kenya, and what would you say are the expected outcomes for reproductive and maternal health care?
So I will pick up from some of the statistics that Mark shared, that we are currently actually facing a global shortage of 900,000 midwives. Now, some calculations have been done, and they've actually found out if we close that gap in the shortage, we're actually going to avert 67% of maternal deaths, 64% of stillbirths, because that's another big issue, 65% of newborn dying, and overall, just for you to understand the impact, is in a year we will actually save 4.3 million lives. Wow. And this is by 2035, and they've calculated. And what we are saying is midwives, as you said, midwifery and midwives, they contribute to the larger workforce around reproductive, maternal, newborn health. But they don't look at midwives and just see they offer care to mothers. They also offer care to women and girls. So I'm talking about adolescent sexual reproductive health services. I'm talking about family planning services and counseling services, HIV, STIs, that whole conversation, the whole continuum of care around reproductive health. Midwives are trained to do that. But as we're seeing, there's a shortage, yet they're available. But and I'm sure Mark will tell you they're there. It is just that now they're not being taken up by the system because the system does not recognize them or respect them, like we've said. Or, we have these other infrastructural issues in terms of funding and resources that are impacting the engagement. So there is a best buy for actually midwifery. There's a best buy for maternal health, the impact on maternal health, newborn health, reproductive health. We must listen, and this is a call to the policy makers, the decision makers, to actually take this seriously.
Indeed, Mark, I see someone asking here, the reason I keep coming to is because for the very first time I think we have a gentleman who is a midwife and, handling this. What would your role, to demystify all this, so that, because you see, for most men, once the lady is expectant, they are hardly in the picture. The much they do is be there in the last few days, and even in the delivery room, some don't even brief to see the whole process. They only wait for the outcome. Talk to us about how you journey with reproductive girls and women from the moment they have attained that age to the moment where they conceive, delivery, and afterwards.
Fine. Now, one thing we try to bring all these girls and women closer, even before conception, because we realize there's a critical role we as midwives should take in their journey. One, in most of the setups, you realize that our pregnant women start taking the preventive drugs very late. You get them taking ferrous and folic maybe in the second and third trimester. That one will not do as good. So we make sure they start the taking of the medication earlier enough, so that at least it can work on the complication that might arise. We first also involve the families, because we realize that we don't involve the male gender. Now what we do as the midwives, before even conception, we bring the families together, both male and female. And we talk to them, their plan and all that. Then we plan to them according to contraception, which one is the best time they can conceive. Now it begins from there. We see the drugs that will work for them before conception. Then after conception, we bring both a husband and a wife on board, because we expect also the support of this man to this pregnancy all through up to the 9 months. During the delivery, any man who will be well prepared at least to come in and help, we also give that assistance, because it's not necessarily, and it's not a must, that delivery should be done in hospital, delivery should be done in this position. So we try as much as possible to do the male involvement in all the stages, and even postnatally, post-delivery, we also involve the male. And again, giving an example, like in Kilifi County, we have tried our best to involve the male gender in all these processes, so that at least they can be as par with the healthcare services offered to their partners.
And, you know, Sandra, while on the one hand this campaign, you know, supports the work of midwives, it has a bit of controversial side which supports the outlawing of traditional birth attendants, TBAs, and some would say that TBAs offer services to those who can't afford hospital services, or where hospitals are, you know, too far. Are you advocating for the outlawing of the traditional birth attendants, and if yes, why?
All right. So first of all, it's already outlawed. So traditional birth attendants are outlawed, only because, and Mark really mentioned this earlier on, we realize mothers are dying, even despite training them, because, you know, we saw that the community really are, you know, advocate. They really want to engage them because of that personalized care I talked about. We you know, they went through training, but still maternal deaths were captured. And so now what we're doing is we want to shift. We're not saying outlaw by you're useless, but now it's sort of shifting their role, because they still play a very significant role within the community, right? And this includes some of the things is talked about, that education and awareness, maternal health, antenatal care, in terms of awareness in health education. Can they go around actually having conversations with these mothers and their communities? They're also very much involved in the birthing process, but as assistants. Because remember how they've got, do you know how they've been trained? Again, I said in quotes, it's through apprenticeship. These are skills that have been passed down from generations and generations based on a very diverse cultural practices. But now we're talking about optimal quality care for our mothers and our newborns, right? So what that means, we actually go back to those who have been trained, and those are the midwives. So we're not outlawing them, but the reason that we are saying we take a different route is because we've not seen a shift. Mothers are still dying, newborns are still dying under their care. So can they now shift to actually these other areas where we have seen the impact in the conversations we're having with the communities, and understanding that journey that is talked about from the antenatal process to the postnatal process, because they do understand it from the cultural and other lenses. So they're still being engaged.
Mark, talking about shifts, then if someone has been doing, perhaps they are even 30 years old or even in their 50s, and, you know, the TBAs, granted, they know a few things about the delivery, because that's pretty much where they come in. Then if they are to shift, the paradigm shift to midwifery, what would be the roles for them, and what would be the options for them, even in the first place? Because, for instance, you may find in a rural area, someone has been a TBA for the longest time, they are the only ones available, and they may be interested in taking up the midwifery profession now formally, to understand the whole process, just as you have narrated to us. Are there any options for them, or do they just, you know, just get outlawed completely?
Fine. One, I appreciate the midwives, the TBAs, because you realize that most of us are as a product. We came through the TBAs, so we can't say that they are bad. But again, we have to look at ways on how we involve them. I'll give an example of a practical I did in a Viragoni dispensary, which is in Kilifi County. I brought up together all the midwives, and the midwives and the CHVs. Then we brought them on board, because we realized the more we say we don't have skilled deliveries in the facilities, most of the deliveries are going on at their home places. So we had to talk to them. And we tell them why we need these deliveries to be conducted in the hospital. Then we also gave them tasks. What do we need them in? So at least they'll have to sensitize. So in every village, at least every midwife knows the number of pregnant women at that particular time. And that report is needed in a facility. Then we see, how do we explain to them the danger signs? How do we explain to the TBAs about giving information to all these mothers, because these are significant focal people in the community. So there's no way you can say we don't need them. Most of the mothers trust these midwives. They trust these TBAs. So we have to bring them on board. So we brought them on board. We explained to them why we need them to refer the patients. And again, there are some systems where we give token to these TBAs. Once you refer a patient, there's something you get back. Because at least we have to check it on a point where if a TBA attends to a woman, there's a token they're given.
But, Mark, on the other side, there's a few who's actually asking. It appears that actually the TBAs are cheaper when you talk about the cost, and they keep, going back to them. And so if someone is charging, let's assume, just a rough figure, if the cost of, midwifery is X, then TBA is half the X, right? And so therefore, if the TBA has been earning this half money through this process, they might as well stick to it. Then how do you then balance this cost as you try to also, entice the TBAs to take up the midwifery role in full perspective?
Yeah. Now, one, we have to all focus on the interest of the outcome of birth of this particular woman and the unborn baby and also the family. So we try to explain to the TBA that as much as you're getting this little token, let's look at, because it's very painful. Right now, we have 362 mortality rate in every 100,000 live births. And we have 23 death in stillbirths in every 1,000 live births. It will be very painful a woman to die or to lose life because of conceiving, because of pregnancy. So we explain to them, yes, there is this token, but let's look at the bigger picture. What is the impact? How do we sort the complications in pregnancy? So I think with good, proper counseling and proper engagement to these TBAs, they listen to, and they at least try to follow what we advise them, because it is for the benefit of the family, benefit of the woman, benefit of the whole society as a whole.
Yeah, Mark and Sandra, we are bringing this conversation to a close. And Sandra, I'm curious to know, would you say as a country we have prioritized maternal, child and reproductive health on a policy and infrastructural level, and what needs to be done?
I think as a country we've definitely taken it seriously. I think within the broader conversation it is happening, and we have investments and leadership structures taking care of this. But just again looking at what the midwives have told us, and even the mothers, that is what we're prioritizing, that there are issues of quality, right? And in terms of the infrastructure, and also I think also sort of addressing what you are talking to Mark about, that cheapness, TB is cheaper than a
midwife.
At the end of the day, do you know, as a woman, as a mother, they have a right to actually receive the highest quality standard of care, even in a facility. First of all, even in terms of, remember, we have Linda Mama, we have all these other subsidies in terms of investments in maternal health. That needs to translate into the level of care that they're receiving. And as part of one of the calls of actions that the midwives have made through this campaign is that they need to, the infrastructural and care process needs to be improved. And when we break that down, what that looks like is in terms at the facility level, they're asking for equipment and supplies, because these mothers are going to the hospital and they're being asked to bring gloves along with them. Why is that the case? Yet they're also being told by their government that they have free maternity care. On the other hand, they go to a facility and they are sharing their bed with 5 other mothers. Literally, that is the case in hospitals, and I'm sure you can attest to that. So that kind of facility infrastructure improvement needs to take place, because it is an obligation by the government to ensure that all hospitals, public and private hospitals, cater to that. In terms of the referral system, ambulance coverage, we've actually had that you can find a mother, there's a referral case at his sub-county hospital that has been made at 9 a.m., but that patient takes the whole day to reach the other hospital, like 6 p.m. And the reason that they're giving is, one, they could not find the ambulance driver. The ambulance did not have fuel. Because it hasn't been serviced for how many months, it broke down along the way, right? Yeah. So those are the kind of infrastructural challenges that we're actually saying through the midwives' voices and the mothers' voices need to be taken care of, because once that quality aspect is taken care of, we'll not be having this conversation around mothers going to the TBAs or giving birth at home because they feel when they go to the hospital or to the health facility, the care that they're getting does not match what they're paying for or what they're expected to receive. Yeah,
indeed, we are really running short of time, but I'll give a minute each to both of you for your, final recommendations and way forward. And I'll start with you, Sandra. We started with you, and then we'll end with the midwife in the room.
All right. Now, I'm just going to mention the key investments that the midwives have asked for. They want investment in education and training so that it is taken seriously. He talked about from diploma level all the way to even PhD. Can that system be set up, and can investments in the quality of training be done? There's also investment in the midwifery, recognition of the midwifery profession. What does that mean? It means actually setting up a midwifery structure. It means actually setting up an independent scope of work for midwives and scheme of service that is recognized across the different across the service delivery chain. And then also the last one is, please let us also respect the profession in terms of leadership, right? In terms of leadership and autonomy, in terms of the pay that they get. They're asking for equal pay for the work done.
Indeed. Mark, as you give your final remarks, talk to us about also whether you feel satisfied in what you do, and whether you'd also encourage other men to take these up, even young boys who want to take up the midwifery profession.
Fine, I'll start with that. One, I am very much satisfied with the midwifery, and I will really encourage the young men, the youth, let's invest in this, let's get into this so that we take care of our sisters, we take care of our mothers, we take care of our relatives, we take care of all the women of reproductive age. It's something that should be put into course and significant. Then for the way forward, I'll categorize it into three: the clients, the providers and infrastructure, and even the policy. For the clients who are getting all this, make sure anytime you need midwifery services, you go to a health facility. As soon as you realize that you're pregnant, do not delay. Do not wait for second trimester or third trimester. Go immediately you realize you're pregnant, or even before you decide you get pregnant. Then for the providers and also the space and the infrastructure, providers, let's give our best to the midwifery services as we look forward to get support from different stakeholders. For the infrastructure, we are really struggling. We need infrastructure, we need space, because midwifery is not, getting pregnant is not a disease. So we have to separate. These mothers don't have to come through the hospital for them to get delivered, because we have to avoid nosocomial infections and all that. For policies, let's make policies and guidelines to midwives so that at least a scope of practice can be open and direct to follow.
And indeed, we trust and hope that all the stakeholders in all these, the government, the private sector, the health sector, all are listening to the calls and the desires and the requests by the Midwives Association, and the conversation that we've been having right here with my guests in studio, who have been Mark Katumila, who is a midwife and vice chairperson of the Midwives Association of Kenya Kilifi branch. I've also been joined in studio by Sandra Morania, who is an advocacy and program manager at White Ribbon Alliance Kenya. That conversation we've been having right here, and of course it proceeds also online. You will be seeing much of this conversation, and please also emphasize on what needs to be done, because we all came through this process. Time now for another short commercial break. I'll be back at the top of the